Good afternoon. My name is Sarah Hahn. I'm a speech language pathologist. I work at Lurie Children's Hospital in Chicago, and I am very grateful to be presenting on the importance of nutrition, feeding tubes, and transplant today for the Pediatric Transplant Conference. A little bit about me, just to give you some background. I have been a speech pathologist since 2010. I've worked in a variety of clinical settings, both inpatient and outpatient. I've worked in NICUs, level 1 trauma centers. I presently work in the cardiac care unit at Lurie Children's inpatient setting primarily, working with a variety of children, some of those who are awaiting or have undergone heart transplantation. I've worked with a variety of patients with different age ranges and medical acuity and diagnoses. This, I think, is super important for today's talk, just because there's a wide range of kids that do require feeding tubes and supplemental nutrition and hydration, not just kids with transplant, but kids who are in need of transplant, but a variety of kiddos. So this is a common topic that I talk about with my families and patients. So let's start a little bit with just nutrition in general and the importance of nutrition. So we know that nutrition does play a key role in the transplant process. Good nutrition is crucial pre-transplant, during, and post-transplant for overall success. There are many studies that back this. We look out for malnutrition for overall success. Good nutrition also generally, we know reduces the risk of many diseases, reduces high blood pressure, lowers cholesterol, improves well-being, quality of life, our ability to fight off illness, which is very important to the transplant population, thinking about our immunocompromised patients. It helps with our ability to recover from illness or injury or be prepared for surgery. We think about nutrition, we're thinking about our energy levels, our stamina, our fatigue, with our everyday activities, as well as with eating and drinking and maintaining nutrition. Also, in the transplant population, a lot of times we think about muscle quality and quantity, so reducing risk factors for sarcopenia, which is very common in our patients who have been waiting for transplant and their rehabilitation status is reduced, and they are malnourished and losing muscle mass. What does a nutrition assessment look like? So this is typically a multidisciplinary assessment. A speech pathologist, so someone in my discipline, would not specifically complete this. A registered dietitian would weigh in the pre-transplant, during transplant phase, and post-transplant phase. In the acute care setting, we look at this on a daily basis. There are different nutritional assessments that we look at. For a subjective global assessment, meaning we take a history, a physical exam, and we use structured parameters to diagnose whether a patient is at risk for malnutrition. We look at their weight gain and growth. We look at a variety of labs and lab results to look at how their overall intake is impacting their nutrition, weight gain, and growth. Most nutrition assessment tools do use various criteria that are subjective and objective to diagnose malnutrition, but primarily in the transplant population, we look at BMI, or body mass index, for our patients. It has been shown as a reliable and valid tool to predict the mortality risk associated with transplant. Conditions commonly associated with concern for malnutrition. So thinking about the transplant populations where we're looking at end-stage liver disease, end-stage renal failure or kidney disease, heart failure, so those in need of heart transplantation, end-stage pulmonary failure, diabetes, and irreversible intestinal failure. What are the risks for malnutrition associated in the transplant population? So risks that, when we're thinking about chronic organ failure leading to a need for transplant, there are a variety of risk factors. So transplant surgery and getting to surgery itself has risk factors when we're thinking about medical acuity, so a stability of a patient as they get sicker and are in more need of their transplant. A lot of times nutrition will take a hard hit because these patients are unstable. Their breathing is impacted, their organ function is impacted, their heart, there may be cardiac functions that are impacted. Then we also think about risk factors related to post-transplant or the actual surgery itself with complications that occur. That may be impact to breathing stability. So does a patient need a breathing tube, for example, to bridge the surgery and then after the post-transplant phase, or even leading up to surgery with a breathing tube in place? We know that our patients cannot eat and drink by mouth. They're at risk of severe malnutrition. So we start to talk about feeding tubes or alternative nutrition, or complications such as life-saving measures like breathing tubes and trachs and vents, or something like ECMO, where you have it's a device that's meant to save our bodily organs and functions and really maintain life. We also think about side effects of the medical treatments that patients who are in the transplant process or have received their transplant, side effects of medical treatments or medications that may impact your nutrition and hydration. So things like mouth sores from chemotherapy or medications, nausea and vomiting from medications as well, lack of appetite and weight loss, dry mouth, saliva changes that make it difficult to eat and drink by mouth, diarrhea impacting weight gain and growth and hydration, changes in taste. So food may just not taste as good anymore. Constipation, depression, so our psychological stability and emotional well-being. Fatigue. Does a patient have the ability to meet their needs by mouth just with energy that they may or may not have? And then most important from my discipline, we are looking at safety of intake. So safety of eating and drinking by mouth. There are periods where our medical acuity or stability are impacted in a way that we cannot let patients and kids eat and drink by mouth because they're simply not safe to do so. So when their breathing status is impacted or their overall, their physiological stability, their body's well-being is not safe to eat and drink. Why might then someone need an alternative or nutrition hydration method? So alternative or supplemental nutrition is a term that we use to talk about feeding tubes. Broadly, alternative nutrition and hydration methods are meant to support quality of life, to support life, nutrition, health, and organ function prior to, during, and after the transplant phase. Those types of alternative or supplemental nutrition look different based on a patient's needs. So if we're starting to talk about a patient and they are not meeting their nutrition and hydration needs, so that's been identified by a medical team, we are thinking about supplemental or alternative nutrition through a feeding tube. We think about them in a couple different categories. So short-term versus long-term methods. A short-term method would look like something like a nasogastric, so a tube that goes from the nose, through the nose, down into the belly or the stomach. An orogastric tube, oral, down to the stomach as well. Oral gastric tubes we look at really in our premature infant population, less so once we're trying to eat and drink by mouth. You can have different routes of intake. So go to the belly or the jejunum based on what a patient can tolerate. So our short-term tubes, looking at our nasal or our oral versus our long-term tubes. Ideally, nasal gastric tubes or oral gastric tubes are looked at as a short-term alternative nutrition method. So 6 to 8 weeks max. Many institutions and patients have these longer, but research really shows that 6 to 8 weeks is an amount of time before we start to see these less ideal outcomes. So repeated aversive experiences from an NG tube. If your kiddo has a tube that's through their nose and it's taped across their face, maybe they also have an oxygen cannula. We are thinking about how many times someone is going in, touching their face, moving the tube, removing the tape, putting the tape on the other side, which may involve then skin injury and breakdown to the face. Possibility of reduced nasal and pharyngeal, so in the throat sensation. There are studies that show that with nasal gastric tubes, we can have reduced sensation in the throat, which may impact safety of swallowing. Reflux impact on reflux, and sinus and esophageal, so the food tube, the esophagus, injury that may occur. So longer term, we're thinking about something like a G tube or a gastrostomy tube or a GJ tube. Gastrostomy tubes. So this is just a couple pictures just to show you generally what a G tube looks like once it's placed. So a G tube is a feeding tube placed into the skin and through the skin and into the stomach, and then delivers nutrition and hydration directly through the stomach. So if you look at this balloon here that holds the tube in place, a retention disc on the outside, and the tube leading out, there's a couple different ports. You have your medicine port, so to administer medicines, your feeding port to deliver whatever type of feeding has been chosen or deemed appropriate for your child, whether that's a formula, whether that's a home blended formula. And then you have your balloon port, which controls this balloon here that's filled with air. G-tubes, I'm not going to go into depth about the surgical procedure behind G-tubes. That is out of my scope of practice, but generally it's a surgical procedure that is a 30 to 45-minute procedure. It can be done laparoscopically, open surgery, or a peg placement. There are studies that show that the safest procedure to place a G-tube is laparoscopically, so via endoscope. Recovery often looks like 1 to 2 days in the hospital, depending on your ability to get to a goal feed. So nutritionists, therapists, doctors talk about your feeding plan. That is what we maybe say, this is the feeding plan where you are maximizing your nutrition or perhaps ready to go home on. Families also need to receive training prior to going home. So training on how to bathe with the G-tube in place, how to dress. What does it look like if clothing is rubbing? What's appropriate clothing to wear over our G-tube? How to administer medications, how to administer feedings based on the type of feeding your kiddo might have. That might look like something like a syringe where gravity draws the food down and goes into the belly. That might look like a pump. A pump delivers at a continuous or a set rate that a family decides is comfortable for their kiddo. And then venting, getting air out, and problem solving. What happens if the G-tube comes out? What happens if there's skin irritation or breakdown? Indications for G-tubes. There are wide reasons why G-tubes, so longer term nutrition and hydration are recommended. In the transplant population, we really look at malnutrition, risks of malnutrition. We also are thinking about medical acuity or stability. So in the bridge to transplant and getting to transplant, how stable is someone to be able to maintain their needs by mouth, and how long do we think it's going to take them to get to a place where they can eat and drink everything by mouth? If someone has significant respiratory needs, so oxygenation, trachs, vents, we think about longer term nutrition. Does a kiddo have a feeding disorder where safety of swallowing is impacted? I'm going to go into that more because that's where my role really comes in a little bit. Dependency on fluid or nutritional supplementation. So thinking about, in particular, our renal or kidney disease population or children with short gut, for example. Does a child need a renal therapy such as CRRT, where we're replacing or making sure electrolyte balance is extremely important for them to survive? A lot of times we need longer term supplementation. Medications, time sensitive, pertinent medications. So in particular with a heart transplant population, anti-rejection medications, medications for heart rate and function. These medications, if cannot be taken orally, must be administered through another nutrition method. Are there other acquired conditions or congenital conditions that kids have had, such as something like an esophageal atresia? So other medical diagnoses that make it difficult for someone to eat and drink by mouth, different types of craniofacial disorders. Chronic poor appetite, nausea due to medical stability. Things also like long-term inadequate intake, kids with failure to thrive, kids who already had that prior to transplant, kids with neurological conditions or progressive diseases. What is my role? So I like this talk a lot because I love what I do. I love being able to help families who are undergoing transplant. I love helping the variety of populations that I work with. But when we think about long-term nutrition, this is never going to be a decision that's made by one party. This is a multidisciplinary conversation with the family, with dietitians, surgeons, GI doctors, social workers, your primary care provider. Everyone needs to weigh in on the reasons for why someone might need longer term or alternative supplementation. My role specifically primarily is to rule out safety with oral intake. So is someone at risk of having a feeding disorder that puts them at risk of not being safe to eat and drink, resulting in inability to meet their needs or respiratory complications? Can someone be efficient and effective? Can they take enough in to eat and drink by mouth with an infant? Can they take their bottle in under 30 minutes to gain weight and grow with an older kiddo? Can they eat a meal in a period of time that allows them to gain weight and grow? And then quality of life and enjoyment. A lot of kiddos who are undergoing transplant don't feel good. They don't want to eat. They become pickier. They become less interested in eating. How can we help as a speech pathologist guide, support the patient therapeutically, as well as the family to make these decisions in when those issues are a big enough impact on their nutrition to think about longer term nutrition? My scope of practice looks at assessing and evaluating safety. So more formally looking at something like a diagnostic test, an instrumental swallowing test, like an X-ray test or endoscopic test to look at safety of eating and drinking. I'll go that in a little bit. Treating for feeding disorders or delays, and referring to other specialists based on other medical concerns or needs. Is a patient really just not showing when I work with them that they are tolerating the formula, the diet that we've recommended by mouth or through their tube? Are they vomiting frequently? Do they have discomfort? Are they showing respiratory concerns? Do I have voicing concerns? In the heart transplant population, we look at a lot of concerns for vocal cord injury with surgery. In our assessment, so with a feeding evaluation, if there is a kiddo who is thinking, if your child has been, identified as needing a longer term or even short term supplemental nutrition method, you likely will have seen speech. You likely will have had a feeding assessment. The primary, again, thing that we're assessing is safety of intake. We're looking at concerning behaviors with feeding. Does this look like coughing? Is someone coughing when they take a drink or drink from the bottle? Are they choking? So have you had to do the Heimlich maneuver? Have they lost breathing when eating and drinking? Congestion, wet phlegmy noises, color changes, difficulty breathing when eating or drinking, efficiency concerns. They're not gaining weight or growing, but they're eating all the time. Respiratory illnesses associated with these symptoms. These concerns might warrant an instrumental or diagnostic swallowing test, such as an X-ray test or an endoscopic test, to rule out whether or not safety is an issue as to why it's impacting our nutrition. I'm going to come back and use this slide in just a minute. So when we look at our feeding difficulties or dysphagia, so in any of the populations that we discussed that are at risk for malnutrition, and in the transplant population, are we identifying a feeding disorder or a feeding difficulty? We look at something, we look at safety of intake. So when we look at when we're watching a patient eating or drinking, and if they have concerns with their safety, so coughing, choking, or congestion, at the bedside, we look at this, and then under X-ray, we look at this. We generally trying to rule out that food or liquid are not going down into the air tube, the trachea, or near the air tube or trachea, and instead they are going where they should go, and through the esophagus down into the belly. Aspiration is when liquid goes into the air tube below the vocal cords. Your vocal cords close when you swallow to protect the airway. And if you take a drink, cough, choke, it's because your vocal cords sensed, they have sensation. They remove the foreign, whatever it is, liquid or food. That is called aspiration. That can be kids who have had frequent surgeries, kids who have had vocal cord injury, kids who have had long-term or intermittent intubations are at higher risk of this, which does look like our transplant population with their medical acuity. So in general, we're looking at safety of eating and drinking. Does food or liquid go near or down into the airway? We look at, if we see that this happens, the risk that kids are at, anyone is at, is a risk for respiratory illness or difficulty gaining weight and growing. We know that kids who have, and adults that have dysphagia often also have difficulty gaining weight and growing. So it's very important to have a speech pathologist a part of the team when you're looking at feeding tubes and thinking about nutrition. If we've identified aspiration or penetration or a dysphagia as a problem, we often look at thickened liquids or diet modifications. I'm not going to go into that today. It's a bigger talk, but we use those to help those difficulties and prevent aspiration or penetration. But it also may warrant alternative or supplemental nutrition or hydration or a feeding tube. The other times that we think about needing shorter term or longer term nutrition and hydration is where our oral sensory feeding disorders, where the variety and volume of intake may not support an ability of a patient to meet their nutrition and hydration needs. So with our transplant population, we know they're at risk for those other side effects, things like mouth sores, nausea, fatigue. This is really, we're going beyond picky eating, your typical picky eater. We're talking about kids who really are not taking in enough that where they can meet their nutritional needs from a variety of different nutritional categories. And then oral motor skills delays. Kids can have delays apart from that are acquired or that they've had from birth. When we think about being behind age expectations with your oral motor skills, we think about, for example, if a kiddo is chronically not eating enough and chewing, a 1-year-old, if they're not really working on their chewing skills because they don't feel good, they're in the bridge to transplant, they are receiving many medications, for example, that make them feel bad, they may lose those skills. We also treat then these kiddos to help support their eating and drinking by mouth. But if they don't have the skills to take in the nutrition that they need, they also may need short-term or longer-term supplementation. Common questions. Common questions that we get as therapists from families. Do feeding tubes affect my child's ability to eat or drink by mouth? If your child is safe, so going back to my role in assessing the safety of eating and drinking, if they are safe to eat and drink by mouth, whether that be a regular liquid, a thickened liquid, a diet modification, then no, they will still eat and drink by mouth. And then if they're not taking enough to gain weight and grow, we will supplement them with an alternative nutrition. That might look like you eat and drink by mouth during the day and you receive a tube feeding overnight. That might look like you eat and drink for 15 or 20 minutes, and then you get a bolus feeding or a scheduled feeding throughout the day. It all depends on the child's schedule and gain and growth needs. How can I support my child's desire and ability to eat by mouth once a feeding tube is placed? Tube feedings really, regardless of the type of feeding, they should be comfortable. They should be given at a rate or a speed where we're not vomiting, where a kiddo isn't uncomfortable, where they're not irritable. The method should be comfortable. So that's up to all of the medical providers to weigh in on short-term and long-term, but then also a family's ability and medical savviness on how they want to give a tube feeding. Does that look like a pump or a syringe? Positioning, how is my kiddo comfortable? Are they comfortable sitting up at the table? Are they not there yet? The mealtime really should mimic a typical scenario. So a schedule that supports every day, something like a breakfast, lunch, and dinner and snacks, where they also, if they're safe to eat and drink by mouth, they can eat before their tube feeding. And that they should have mealtime partners. The family, they should not be apart. Their tube feedings should be still on a schedule that supports. We get to eat with our family and share in the social aspect of meal times. If they are comfortable, that really enhances quality of life. Longer term, so the longer term supplementation, like a G tube, from a speech therapist perspective, I think about advantages and disadvantages. With the advantages that from my discipline that we often talk about are we have less intrusive or invasiveness at the level of the mouth and face. Kids who have shorter term methods, so NG tubes, but longer, often tend to be more sensitive and more aversive to stimuli at their mouth. The G tube can be more normalizing. So instead of having something on your face, it's under the clothes. Longer term impacts with laryngopharyngeal sensation, meaning sensation in the throat, sensation to protect my airway. When I'm eating and drinking, we can see impacts with NG tubes versus G tubes. And caregiver ease and satisfaction. I have not worked with, to this date, a family who has regretted getting a longer term method of hydration and nutrition when a medical team and the family have come to that decision. We do know, though, that this is a surgical procedure. We need anesthesia. There can be irritation around the site, leakage, dislodgement. There are studies that do show that certain populations do have more frequent hospitalizations related to G-tube difficulties. But most, again, the caregivers that I have worked with, and I have worked with many families that have had to made the decision to make the decision for a G-tube have not regretted it. Myths or common misperceptions. The tube symbolizes that my child will never eat again. No, G-tubes, NG tubes, if your child again is safe to eat and drink by mouth, is a bridge to improving that. Oftentimes we find that once kids are better nourished because they are getting ongoing supplementation or additional supplementation in a way that takes the burden off their oral feedings, they tend to eat better as well. My child will be treated differently. Longer term, so again, G-tubes, I have found that most families have loved that that this is a more normalizing method of acquiring nutrition, that they can't see anything on their face. And my child will need the tube forever. If your child is eating and drinking and gaining weight and growing by mouth, we, dietitians, speech pathologists, medical providers will talk about G-tube weans or G-tube removal. Oftentimes the G-tube can just be taken out. It does not need any surgical intervention to be removed. I'm not going to go into all the research today, but in general, when we're thinking about nutrition and hydration in the transplant population, so poor nutrition status based on a variety of criteria has been identified as a risk factor for adverse post-transplant outcomes among all organ transplant types. I've included the research at the end. Some other great resources from the speech pathology world would be at the bottom here, Suzanne Evans-Morris, Marcia Dunn Klein. They have fantastic websites on G-tubes, tube feedings, oral feedings by mouth. There are also great resources for families. Abbott makes these, but if you go onto websites, there are tube feeding coloring books that are like a social story, but also go through what is it like to get a G-tube that you can go through with your kiddos. So I will let you go through the research. It's all there. Thank you so much again for this opportunity. And I appreciate any questions anyone may have.
Hi, Sarah. Thank you so much for presenting to us today. We appreciate it. This is a wealth of information, and so wonderful to have these resources, which we can have available as a downloadable document as well for families when you're looking in the chat. I'll just go ahead and relay our own personal story. My son had a G-tube for many, many years, and I fought it tooth and nail at first, but after we got that in, we were so happy to have it. It was so easy to be able to feed him and get him his nutritional needs at a very difficult time for him while he was able to take his time, learn how to eat the proper way through speech interventions and occupational therapy interventions and all of these amazing people that came together to help him learn how to eat and do all of these things really successfully, get those missed milestones that a lot of our kids missed when they're waiting for their transplant. So you've covered so many questions that we've already had about criteria to put this in. A big question is always, how do you know if you're getting adequate nutrition? And you said it would be great to have a nutritionist on at some point and talk about some of those issues as well, because we get questions about blended diets and putting those through the tube and all of that kind of good stuff, because families obviously want the best for their kids, on top of everything else. We get the formula, but we also like to give them some real food too, and have them be a part of that dining dynamic, that social impact that you spoke about earlier, which is so important. I'll ask you another question, if that's okay. Long term, a lot of parents worry about the scars. So with boys, it's pretty easy. They just scars pretty cool. I didn't believe that at first, but now that my son is 15, he thinks the scar is pretty cool, but girls worry about that too. Is there anything they can do for scarring that may happen with G-tubes?
That's a great question. So I would probably have to refer that over to like a pediatric surgeon. I do know just the actual removal of the G tube itself is simple. Many families just remove it and then the tissue closes. And then you're followed up with like a wound team, depending on the hospital and care providers you work with, but pediatric surgery and then a wound team to make sure you have the best outcomes to reduce scarring.
That's amazing. And thank you, because that's hugely important. And a lot of parents don't know that we can ask for a referral to a wound team or sometimes even a plastic surgeon. So we have a lot of things at our disposal that we often don't know that we could just ask the question and get a referral for our
Yeah,
children.
and I think going into it, when your child is ready to have that removed, having that that knowledge and those resources are great because I think a lot of times too, because medical providers, particularly surgeons, once kids are meeting their needs and then they've been identified as meeting their nutrition, they can have their tube out. It's a simple thought for them. So I think those longer term questions are great for families to come in with.
Absolutely. And thank you. This has been a great presentation. The only other things I can think of as possible questions sometimes that we get, I know supplies. So sometimes those are hard to come by. Obviously, clean those really, really well. No one wants to end up back in the hospital with any kind of infections. And they should give you a certain number of supplies that you're able to get through all of that. I know that's kind of a stressor sometimes, but you can always go back to your team and ask for those as well, right?
Yeah, and that also is great for questions for the either case management, social workers, and your DME provider on making sure you're ahead of the game and thinking about extra supplies, additional supplies, because it's inevitable that an NG tube or a G tube will come out. And I think families do not, particularly families with the NG tube, they know as their kids get more mobile, they come out, they've been trained in placing them. But making sure too, it's the right with thinking again about supplies, NG tubes, we shouldn't see them used long term, but a lot of kids have them for a long time. So thinking about the size of the tube is also really important. We don't want a tiny infant with a really big tube, and we don't want a big kid with a little tiny tube. So thinking about that as kids grow is important. But then, yes, having good conversations with your social worker, case manager, and then the DME provider.
Excellent. Also, I know from personal experience that when we went to get some compounded prescriptions that go through the tube, that the pharmacies are really great to give you extra supplies if you just ask for it.
Yes, great. Yeah. We also too, like I hope other providers this way in the hospital, like the family comes in and they need something. I'm going to make sure your kid gets their nutrition. So here's a syringe or whatever you need.
Exactly. And that the family can call, that first or second time they have to put the G tube back in after, or the NG tube after it comes out. We've all been in that position as parents of 2B kids. And it's definitely, kind of hard. You're terrified that first time. So there's nothing wrong with calling your provider and having them kind of walk you through it that first time. You'll get it right. It takes some practice and we all get there. For the parents, any great G-tube tips, drop in the chat. We'd love to hear it. I know there's some really cute G-tube covers and G-tube covers now that you can buy online. Super cute. You've probably seen some too, Sarah.
I've seen some really great things on Etsy for like things to the back of a shirt for onesies or shirts for NG tubes. So yeah, people are I think because we're using them more with our medically complex and more fragile kiddos, and that people are creating excellent resources for families. But yeah, Etsy, I feel like I've actually found the most like things.
I love them. I love Tubesies. They
Mhm.
have some covers that go on there. I've seen adaptive care, like clothing. We used to
Mhm.
love button-up onesies so you could get the
Yep.
tubes
Yep. For the
through.
kimono ones too are really nice.
So many cute options for these kids now. It's just, we love to see the evolution of it all. Sarah, thank you for your time. For the
Thank
parents in the audience,
you.
if you have any questions, please email them to hello@transplantfamilies.org. Sarah, any last words?
Um, I think just knowing that we know that this is a big decision for families when we're thinking about feeding tubes. I do those X-ray swallowing studies that I was talking about a little bit. And just yesterday, I had a family who was in for a swallowing exam in preparation for their G tube placement. And it's always an emotional decision. We know that. And no one should ever be insensitive to that. We are here just to advise families. At the end of the day, it is your decision, but we hope that we can provide the best information in our disciplines.
Thank you, Sarah, for your time today. We will follow up with what I'm sure will be lots of questions, but we appreciate this wealth of knowledge. Thank you so
Thank
much.
you. Thank you so much.